Let's begin with the case of a 13-year-old ballet dancer who fell from her partner's arms during a lift and landed hard on the posterior medial aspect of her flexed elbow. She had immediate acute pain in her elbow and paresthesia, that's pins and needles, in her ring finger and pinky finger. But the skin of the arm and forearm were not affected. She was left with difficulty adducting her wrist in what's called ulnar deviation. She had limited flexion of her wrist, as well as problems making a fist. In fact, movements within her hand were greatly impaired. What happened during that traumatic fall to cause these symptoms? We covered the bony landmarks of the radius and ulna in the last lesson, since the forearm bones are the insertion of most muscles in the arm region. In the forearm, origins and insertions get quite variable. We'll find muscles that originate on the humerus, radius, ulna, or combinations of those bones, and forearm muscle insertions on the radius, carpals of the wrist, metacarpals of the hand, and the bones of the digits. We already know that in the limbs, muscle origins are always proximal and their insertions are always distal. There are also many muscles in the forearm and hand, and they tend to get smaller as we go distally. This makes sense when we consider the intricacy of the movements of the hand, fingers, and thumb, as well as the increasing numbers of bones and joints as we progress down the upper limb. As a reminder, the radius is lateral and the ulna is medial, and the two bones in the forearm are joined by the interosseous membrane. That deep plane of fascia combines with the sleeve of antebrachial fascia and its attachment to the bones of the forearm to create two compartments in the forearm, an anterior and posterior. Many muscles in the anterior forearm cross the anterior wrist. So how would they act on the wrist? Thinking of muscles like puppet strings, it makes sense that these will flex the wrist. Several of the anterior forearm muscles also reach the digits and flex them as well. But in the anterior compartment of the forearm, we'll also find a pair of muscles that pronate the wrist and hand, which we know happens at the elbow. In the posterior forearm, we have counterpart muscles that extend the wrist and digits, and a supinator of the forearm at the elbow. Also in the posterior forearm, we have a group of muscles that act specifically on the thumb. But at the lateral edges in both the anterior and posterior forearm are muscles that abduct the wrist and hand, an action also called radial deviation, since we're deviating the hand toward the radius. And at the medial edges in both compartments, we also have muscles that adduct the wrist and hand, also known as ulnar deviation. Since muscles in the proximal forearm may pass their tendons all the way to the wrist and digits, we have thickenings in the antebrachial fascia at the wrist known as retinacula. There's a flexor retinaculum at the anterior wrist that is continuous with the extensor retinaculum at the posterior wrist. These act like bands or bindings and function to keep the tendons aligned with the joints they act on. In other words, the retinacula prevent the tendons from a phenomenon known as bowstringing, in which they would bend away from their alignment with the bones they act on, as if in the shape of an archer's bow. Anteriorly at the wrist, part of this flexor retinaculum forms the compartment for tendons that's known as the carpal tunnel, and we'll look at that in some detail in the next lesson. Let's begin our specifics with the anterior compartment, which has either 7 or 8 muscles in it, depending not on what reference you consult, but on human variability. A couple of muscles in the body are quite commonly variable, and palmaris longus is the first of those we'll encounter. The 8 possible muscles are subdivided into a superficial layer and a deep layer. And the variable palmaris longus muscle is superficial. and in a bit, we'll do a little test to see if you have it. We have either 4 or 5 muscles in the superficial group and 3 muscles in the deep group. What links the superficial muscles together is that all have at least part of their origin off the medial epicondyle of the humerus, an area known as the common flexor origin, since nearly all of these muscles flex the wrist or digits. It should also be noted that when you look at the anterior forearm, you can readily see some muscles of the posterior forearm at this lateral edge. That wad of muscle seen at the lateral elbow consists of 3 muscles of the posterior forearm that wrap around to the anterior side. We'll cover those later in this lesson. Now, starting at the medial border of the triangular cubital fossa, the muscles of the superficial group in the anterior forearm start with pronator teres, the smallest of the group. Teres means round, since the muscle is rather round in cross-section. It originates off the medial epicondyle of the humerus, and in order to pronate or supinate, do you recall which forearm bone it must insert on? Yes, it inserts on the radius, about midway down its shaft. Since pronator teres crosses the anterior elbow, it also aids flexion of the elbow. Next in line off the common flexor origin is the flexor carpi radialis. That means a flexor of the wrist on the radial or lateral side. It takes origin off the medial epicondyle and passes obliquely down the forearm toward the wrist. It inserts on the second and third metacarpals in the palmar hand. Despite having carpi in its name, it doesn't insert on carpal bones of the wrist themselves. Now, given its lateral insertion, it causes abduction of the wrist, alternatively called radial deviation. Flexor digitorum superficialis, as its name implies, is a superficially placed flexor of the digits, specifically the 4 fingers. It has a broad origin, with part coming off the medial epicondyle, part off the coronoid process, remember that's on the ulna, and also takes origin off the anterior radius. Its muscle belly sends 4 tendons through the carpal tunnel and on to insert on the middle phalanges of the 4 fingers. Each finger contains 3 phalanges, a proximal, middle, and distal. Then, on the medial side in this superficial layer is the flexor carpi ulnaris, which takes origin off the medial epicondyle and then inserts on 2 of the carpal bones of the wrist and the 5th metacarpal of the palm. Flexor carpi ulnaris is so medially located that it doesn't only flex the wrist, but also performs wrist adduction, called ulnar deviation. Those are the 4 standard muscles of the superficial group of the anterior forearm. But what about palmaris longus, the variable muscle? Like the other muscles of the superficial group, it originates off the medial epicondyle. When present, it has a small and proximal muscle belly and a long tendon that inserts on the flexor retinaculum that forms the carpal tunnel. Palmaris longus is the most variable muscle in the world. Its presence ranges widely from about 36% to nearly 99%, depending on the research study, but interestingly, its prevalence varies widely in studies conducted on different populations around the world. And this is a cool party trick. You can tell whether you have it or not. Flex your fingers to make a claw-like motion with your hand, and then oppose your thumb to your little finger, slightly flex your wrist, and tense up almost like you're squeezing an imaginary stress ball. If you see a thin tendon pop up very superficially at your anterior wrist, it's palmaris longus. But if you see only a wide, flat prominence, that's the grouping of flexor digitorum superficialis tendons. Sorry, no palmaris longus for you. Now, usually if people have one, they have it in both forearms. And if a person has it, it's potentially a spare part. That's because the tendon can be salvaged and used in a tendon graft. For example, if they get their hand caught in machinery and need a tendon repair. And the beauty of an autologous graft, that's a transplant a person gets from themselves, is that it's not foreign tissue that might cause rejection. If you don't have a palmaris longus crossing the anterior wrist, not to worry. You can still do wrist flexion with the best of them. Before we leave the superficial group of anterior forearm muscles, did you know that so-called golfer's elbow is a form of tendinitis associated with the common flexor origin for those 5 muscles? It's clinically known as medial epicondylitis and can result from the repetitive amount of gripping and wrist flexion needed in golf. In some cases, micro tears occur at the attachment of the muscles that originate at the medial epicondyle, and pain can radiate down the anterior forearm. Other sports can aggravate this area too. For example, incorrect form when throwing a baseball is called pitcher's elbow, but it's really the same disorder. Now, on to the 3 muscles in the deep group of the anterior forearm. None of these originate off the common flexor origin of the medial epicondyle. The largest is the flexor digitorum profundus. It takes origin off the shaft of the ulna and its coronoid process, as well as off the interosseous membrane, since it's deep, as the name profundus implies. Like its superficialis buddy, flexor digitorum profundus crosses the wrist within the carpal tunnel, and its 4 tendons insert on the distal phalanges of the fingers. So not only is flexor digitorum profundus located deep, but it goes deep, as in goes long like tossing a football. Since the superficialis muscle attaches to the middle phalanges of the fingers, while profundus goes the long way and inserts on the distal phalanges of the forefingers. Because flexor digitorum superficialis and profundus both cross the anterior wrist, they also help flex the wrist. The second muscle of the deep anterior forearm is the flexor pollicis longus. And given that pollex means thumb, this is a flexor of the thumb that originates on the radius and interosseous membrane and inserts on the distal phalanx of the thumb. The thumb only has 2 phalanges, not 3 as in the fingers. Flexor pollicis longus also passes through the carpal tunnel made by the flexor retinaculum of the wrist. So the carpal tunnel contains 9 tendons belonging to 3 muscles. 1 tendon from the flexor pollicis longus, 4 tendons from flexor digitorum superficialis, and 4 tendons from flexor digitorum profundus. As we'll discuss in the next lesson, the main issue is that the carpal tunnel also contains the median nerve, which becomes the problem for those with carpal tunnel syndrome. The last of the deep muscles in the anterior compartment of the forearm is pronator quadratus. That's the companion muscle to pronator teres. Teres means round, but this pronator is quadrangular in shape. It's one of my favorite muscles for its unusual appearance. It's flat, nearly square, and runs completely perpendicular to the 2 bones of the forearm. Pronator quadratus originates on the distal ulna and inserts on the radius in order to pronate. So those are the 7 standard muscles and 1 variable muscle of the anterior forearm, most of which act to flex the wrist or digits. What about their innervations? If you remember from our study of the brachial plexus, the median and ulnar nerves are terminal branches, but they haven't had any jobs yet. They pass through the anterior arm to reach and supply muscles of the anterior forearm, and we'll see they also supply some muscles in the palmar hand. Passing through the anterior arm, the median nerve goes right through the middle of the cubital fossa. In fact, the mnemonic TAN, T-A-N, is used for the relationships of the central structures at the cubital fossa. The T is for the tendon of the biceps brachii, the A is for the brachial artery just medial to it, and more medial still, the N stands for the median nerve. That's why those drawing blood in the cubital fossa shouldn't jab too deep, since just below the bicipital aponeurosis are the brachial artery and median nerve. Now you might think, what's the difference if a blood draw uses an artery instead of a vein? But arteries carry blood at much higher pressure than veins, so will require more pressure and time to stop the flow of blood. Blood is typically only obtained from an artery for a special test called an arterial blood gas, or ABG. And besides, the radial artery at the wrist is the more common location for that, though the brachial artery can be used. So back to the median and ulnar nerves. The median nerve passes through the center of the cubital fossa to reach the anterior forearm, but the ulnar nerve does not. The ulnar nerve passes through the medial arm and then ducks behind the medial epicondyle on its way to the anterior forearm. And at the elbow, the ulnar nerve sits between the medial epicondyle and the olecranon process. That's what causes the pins and needles feeling when you accidentally bang your so-called funny bone, which is the medial epicondyle. If you want to simulate that on yourself, find your medial epicondyle and your olecranon process, and then press hard between them and hold it for a while. Pretty soon you should feel pins and needles in your little finger and the medial side of your ring finger as you compress your ulnar nerve. Now, once the pair of nerves reach the forearm anteriorly, most muscles are supplied by the median nerve. Only 1.5 anterior compartment muscles are supplied by the ulnar nerve. In the superficial group, the median nerve supplies all muscles except the one with ulnar in its name, flexor carpi ulnaris. So the median nerve supplies pronator teres, flexor carpi radialis, flexor digitorum superficialis, and palmaris longus if it's present. In the deep group, 2.5 muscles are supplied by the median nerve. And to be even more specific, the anterior interosseous branch of the median nerve, which comes off the median nerve and dives deep in the anterior compartment to descend along the interosseous membrane, thus its name. The flexor pollicis longus and pronator quadratus are both supplied by this anterior interosseous nerve. But the flexor digitorum profundus has dual innervation from both the anterior interosseous branch of the median nerve and the ulnar nerve. The medial half of flexor digitorum profundus is supplied by the ulnar nerve, and the lateral half by the median nerve's anterior interosseous branch. To help them remember, I tell my students that all muscles of the anterior compartment of the forearm are supplied by the median nerve except 1.5 muscles. And the one is the only one with ulnar in its name. But to remember the muscle that's half supplied by the ulnar nerve, you need to think deep, and profundus means deep. The posterior forearm has even more muscles than the anterior compartment, 11 muscles total. These are typically divided into 2 main groups. There's a superficial set of 6, and then 5 deeper muscles. The superficial muscles all take origin on or just proximal to the lateral epicondyle, so it's called the common extensor origin. The 6 superficial muscles are then sometimes subdivided into 2 groups. A superficial lateral group of 3, and those are the ones we can see even from the anterior side at the lateralmost aspect of the forearm near the elbow. And a superficial posterior group of 3 that can't be seen anteriorly. All of these are supplied by the radial nerve or one of its branches, and most extend the wrist or digits or act on the thumb. The superficial lateral group, seen just lateral to the elbow, are the brachioradialis, the extensor carpi radialis longus, and extensor carpi radialis brevis. Now, brachioradialis doesn't cross the wrist. Its name tells us that it starts on the bone of the brachium, which is the humerus, and it inserts on the radius, specifically the distal radius, including its styloid process. Brachioradialis is very unusual for a posterior forearm muscle because it actually crosses the anterior aspect of the elbow, so it flexes the elbow, but not in the same way that biceps brachii and brachialis act. Brachioradialis is also known as the handshake muscle or the drinking muscle because it flexes the forearm when the palm faces medially, as if you were shaking hands or drinking from a glass or a can. While biceps brachii and brachialis of the anterior arm flex the elbow when the palm is supinated or facing up, as if doing biceps curls with a free weight. The other two members of this so-called superficial lateral group, extensor carpi radialis longus and extensor carpi radialis brevis, are the only carpi muscles that have longus and brevis counterparts. Not only do they extend the wrist, as their name implies, but they also cause radial deviation or abduction at the wrist. The extensor carpi radialis longus is more superficial and inserts on the proximal base of the second metacarpal, while the extensor carpi radialis brevis is deep to its longest buddy and inserts on the proximal base of the third metacarpal. Now, the other three superficial muscles are more posteriorly located, and so are sometimes called the superficial posterior three. They are the extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Unlike the anterior compartment where there's a pair of flexors of the digits, superficialis and profundus, the posterior compartment of the forearm simply has an extensor digitorum, period. It sends its tendons down to extend all four fingers. Often its tendons have connections between them on the dorsum of the hand. But the little finger has an additional tendon from a small muscle called extensor digiti minimi that passes from the common extensor origin of the lateral epicondyle down to the proximal phalanx of the pinky finger to extend it. Extensor carpi ulnaris is at the medial edge of the posterior forearm, and it inserts on the proximal base of the fifth metacarpal. That's the bone of the palm on the little finger side. In addition to extending the wrist, extensor carpi ulnaris causes wrist adduction or ulnar deviation. Since I mentioned golfer's elbow, before moving on to the deep muscles of the posterior compartment, we should also cover the more commonly known tennis elbow. It's clinically known as lateral epicondylitis because it relates to repetitive motions of the extensor muscles that take origin from the lateral epicondyle. Of course, other racket sports can cause lateral epicondylitis, but it's also seen in butchers, painters, carpenters, and others whose work requires repetitive extension of the wrist and fingers. In my case, my doctor called it gravedigger's elbow, since mine resulted from my forensic work. Years ago, on a single afternoon, I had to exhume 2 shallow graves in the cold, mostly using a hand trowel. Now, let's discuss the 5 deep muscles of the posterior forearm that don't take origin off the lateral epicondyle. This group includes 3 muscles that have the unusual name, the snuff box muscles. The surface landmark known as the anatomical snuff box is a triangular region on the posterolateral aspect of the thumb where 3 muscles of the posterior forearm travel to reach the thumb. This area gets its strange name because in the old days, people who did snuff, which is a dry, powdery tobacco mix, would put a pinch of the mixture on the flat spot at the back of the thumb and then snort it into a nostril. The snuff box muscles are also known as the outcropper muscles because they crop out between the superficial lateral and superficial posterior muscles, and so they're helpful in differentiating those two superficial groups. The 3 outcropper muscles, or snuff box muscles, are the extensor pollicis longus, extensor pollicis brevis, and the abductor pollicis longus. The triangle of the anatomical snuff box is caused by the fact that the extensor pollicis longus travels by itself on the more medial aspect of the posterior thumb, while the extensor pollicis brevis and abductor pollicis longus travel together on the lateralmost aspect of the posterior thumb. Now, I often tell my students that the snuff box separates the 2 extensor muscles of the thumb and also separates the 2 longest members of this group. We'll talk more about thumb actions, which aren't as intuitive as you might think when we cover the hand. Extensor pollicis longus originates from the midshaft of the posterior ulna and the interosseous membrane, and it inserts on the base of the distal phalanx of the thumb. The extensor pollicis brevis originates from the midshaft of the posterior radius and the interosseous membrane, and inserts on the base of the proximal phalanx of the thumb. So again, we see longus going the long distance and brevis stopping short, thus their names. Abductor pollicis longus originates on both the radius and ulna, as well as the interosseous membrane, and it inserts on the posterior surface of the base of the first metacarpal. It does have a brevis buddy within the hand, as we'll see later. One of the remaining 2 deep muscles of the posterior forearm is the extensor indicis. Like the little finger, the index finger has its own extensor muscle, in addition to getting a tendon from extensor digitorum. As a memory device for the 2 digits that get an extra extensor, I tell my students to use their fingers in a rock on or party on sign, or Texas Longhorn sign for our college football fans. I'm not sure why these 2, but it is interesting that if you put your palm down on a tabletop and try to lift each finger, usually the index and little finger do a much better job than the middle or ring finger. In many people, the ring finger does a pretty poor job of hyperextension to raise it off the table in particular. Our last forearm muscle is the posterior compartment's supinator. No longus, brevis, teres, quadratus, yet we know that its supination is aided by the biceps brachii. The supinator is an interesting looking muscle. It spirals around the bones of the forearm. It originates on the lateral epicondyle of the humerus and proximal shaft of the ulna and winds around to insert on the proximal third of the radius on its posterolateral side. As for innervations, if you recall, the entire posterior arm and forearm are supplied by the radial nerve, but there are specifics. Brachioradialis and extensor carpi radialis longus are said to be supplied by the radial nerve. But once those 2 are innervated, the radial nerve splits into a superficial branch that is entirely cutaneous and a deep branch that supplies extensor carpi radialis brevis and the supinator. Once the radial nerve's deep branch emerges from the distal border of the supinator muscle, it's renamed as the posterior interosseous nerve, which supplies the other 7 muscles of the posterior forearm. Now, if you want a rundown of those 7 again, they're extensor digitorum, extensor indicis, and extensor digiti minimi, extensor carpi ulnaris, and the three muscles of the snuff box group, which are extensor pollicis longus and brevis, as well as abductor pollicis longus. See, I told you there were a lot of muscles in the posterior forearm. And when you add those 11 to the 7 or 8 muscles in the anterior forearm, we have no fewer than 18 muscles in the forearm. Before we close, we should return to our clinical correlation. Our young ballet dancer felt hard on her bent elbow, resulting in immediate pain in her pinky and ring fingers, as well as muscle issues when attempting to flex the wrist, make a fist, and during wrist adduction. Which compartment was primarily affected? If you said the anterior forearm, you're correct. That's where muscles that flex the wrist and digits reside. Do you remember what nerve passes around the posterior elbow and can elicit that funny bone feeling, which is typically only experienced in the ring and pinky fingers? You're correct if you said the ulnar nerve. And if you recall, it supplies the flexor carpi ulnaris that functions in wrist adduction, as well as the medial half of the flexor digitorum profundus that helps flex the wrist and digits. But what if I told you that X-rays showed the ballet dancer had a fracture that caused avulsion of the medial epicondyle? So not only is the ulnar nerve damaged, but the muscles of the superficial anterior forearm lose their anchor on the humerus. This can include pronator teres, flexor carpi radialis, flexor digitorum superficialis, flexor carpi ulnaris, and palmaris longus if she has one. That's a significant injury, but it often heals on its own with casting of the flexed elbow. Sometimes, though, surgery is required. She didn't lose feeling in the skin of her forearm since the ulnar nerve does not supply that skin. The skin of the forearm is innervated by the superficial branch of the radial nerve, the lateral antebrachial cutaneous nerve, which is the continuation of the musculocutaneous nerve of the arm, and the medial antebrachial cutaneous nerve. That came all the way from the medial cord of the brachial plexus. Why can she still do some ulnar deviation? Why isn't it knocked out completely? That's because her extensor carpi ulnaris is still functioning. In fact, in the absence of injury, when we perform ulnar deviation, both the extensor carpi ulnaris and flexor carpi ulnaris get involved, which cancels out their extension and flexion functions, leaving us with only wrist adduction. The same is true of radial deviation. When extensor carpi radialis longus, extensor carpi radialis brevis, and flexor carpi radialis are used, the end result is simply wrist abduction. Put your hand on your wrist and use ulnar and radial deviation to wave goodbye, and you'll feel this happening.